Hello, and welcome to the fourth webinar of the six-part series. Tonight I'm talking about Step 3, Refashioning the Wound Edge. Hello, I'm Terry Swanson, and I'm a nurse practitioner of wound management. Several people have written in and asked which consensus document that I'm talking about. So whenever I'm talking about the consensus document, I'm talking about this document, which was published this year in the Journal of Wound Care. It is the Delaying Hard-to-Heal Wounds with an Early Anti-Biofilm Intervention Strategy, Wound Hygiene. It's a long title, so if you just want to shorten it to Wound Hygiene, that's fine. And you can find this on the web page provided, or you can just Google Wound Hygiene. This easy-to-understand process is 4 steps. So in the first webinar, I talked about the rationale for wound hygiene. Then I talked about therapeutic cleansing of the wound and the peri-wound. Then I talked about proactive debridement. And tonight I'm talking about refashioning the wound edge, following these 4 simple steps. The whole document talks about hard to heal wounds. And so this is a definition provided in the document. It's a wound that has failed to respond to evidence-based standard of care, so your normal care, and it's regardless of the wound duration. So if it has slough, increased exudate, or increased size, then it's hard to heal. And all hard to heal wounds contain biofilm. As previously explained in the webinars before this, that the wound is in imbalance. So we have to be proactive, and that is why wound hygiene is so important if you have a wound that is failing to heal. So why do we refashion the wound edge? There are 4 main components. There's lots of reasons, but 4 main components. And that is autolytic debridement is insufficient, really. So anytime that you're dealing with biofilm, it has to be multiple levels of activity or treatment to that wound. Biofilm is most active at a wound edge and prevents that new tissue from migrating across that wound fluid and wound base. Refashioning goes beyond decontaminating the wound edge. The agitation actually stimulates the healing cells and the growth factors, and that helps advance the wound edges. Now, anytime that we're doing wound care, it all starts with the assessment. With each dressing procedure, these are the factors or the parameters that must be done with each dressing change. Now, I've given you a wound here, which is pilonidal sinus. And as you can see from the wound edge, it's macerated, so there's too much moisture. So if you look on the diagram, and this is our whiteboard that we have in the clinic, you can see the length and the width, and then the depth was 1.7. The tunneling is expressed by using that clock face at 12, 3, 6, and 9. It's 0.5 centimeters. If you look at the wound picture, that is a little bit further away, you can see the peri-wound. So that's the assessment of the tissue or the skin around the wound. And you can see from that, there's a bit of irritation, a bit of folliculitis, and a bit of irritation from the taping or the adhesive that's going on. So I have to determine, is this wound improved? Is it unchanged, or is it deteriorated? And if it's unchanged or deteriorated, what do I do next? Because I'm not going to continue to do the same thing, so I have to do something different. Obviously, this wound has too much fluid, so I have to improve the moisture balance or the absorption of the dressings that I put on. So I might increase the wound feeler to be more absorbing and have a more absorbing dressing and keep the frequency at the same time. Or I might keep the same dressing regime but increase the frequency. Regardless of either strategy that I do, I'm also going to use a barrier film, a liquid film, around the wound, immediate wound area, and the greater peri-wound area to protect the skin. Now this is a patient who came to me for his right limb, and I'll show you his left foot in a moment. But this type of wound requires more than just anointing of that. So you can see I've already cleansed the leg, haven't gotten to the wound yet. But this is unhealthy tissue, and even with good cleansing and debridement, there's still some non-viable tissue because what it reveals is a desiccated tendon. There are some healing indicators, but this is a patient who's at high risk from losing his limb. He has peripheral arterial disease, end-stage renal failure, and is on dialysis 3 times a week, just to name a few of his comorbidities. Now, in our service, in my clinic, we always, especially on presentation, take off both shoes and socks and roll up both pant legs. Now, he came in for, the referral was for that right leg, but folks, this is his left foot. You can see he's already has amputations, previous amputation. He has stable necrotic tissue on that 5th toe, but what he didn't tell the nurses was that he dropped a can on his toe last week, and he's been putting Band-Aids on it. So when I took off his sock, I was quite alarmed and shocked. This is unstable eschar. So what do? Well, this gentleman, I referred him immediately back to the vascular service, and he ended up with a guillotine 4-foot amputation. Anytime that we're about to do a wound dressing procedure, you need to anticipate the procedural and the operative pain, and I've talked about this in previous webinars. Easily managed with simple analgesia. So I often get my patients to take some paracetamol before they come, which is usually at least an hour before I see them. If I'm going to be doing debridement or aggressive cleansing, I'll use topical anesthetics, such as lignocaine or lignocaine and prilocaine combination. And then non-pharmacological. So this is diversion therapy, such as talking to your patients about gardening, their pet, one of their favorite topics. Some people have more modern augmented reality options. Either way, it's combining all of these strategies to make sure that your patient is comfortable. I always tell my patients, if you experience pain or you become uncomfortable, tell me and I'll stop. And if I can't get it under control or we can't proceed in comfort, then we stop for today. Now this is my backyard, not literally, it's an hour away, but this is the 12 Apostles at the end of the Great Ocean Road down by Port Campbell, and I live in Warrnambool. But Randy Walcott in the consensus document talks about cliffs and beaches. And we know with repeated trauma, such as the waves and the tides, erode this limestone. So does infection and repeated trauma erode our wound edges. So he talks about cliffs and beaches, and this is just a prime example. This is one patient where before you have before the cleansing and the debridement, and then you have on the right the after. So you can see after I've cleansed it that there actually is cliffs to those edges. You just don't know the depth. There is some healing indicators, but on the more proximal wound, at the distal end of that, you can see that there's trauma where the patient actually bumped it. But you have to, so that flat area would be considered the beach, and the tops or proximal end would be the cliff. So I'll explain this a little bit further. The first 2 photos are wounds that are on the plantar surface of the foot. When we are treating these type of wounds, most commonly seen with patients with diabetic foot ulcerations, is this hyperkeratotic tissue or callus around the wound. Randy Walcott promotes, and I agree with, that not only do you have to cleanse and remove that hypercallus tissue, but you actually need to remove the cliff. So what does the cliff look like in this first patient? So I highlight that with the blue, and he would advocate that that whole circle, highlighted in light blue, be cut away through a scalpel or scissors to remove that, and then that whole beach or base of that wound is treated. You still do the offloading with podiatry felt or however the podiatric service is providing it for that particular patient. But that cliff needs to be dealt with. The next photo is on the toe. Again, you have the hyperkeratotic tissue or the callus. And again, you have the circle outlining the area that is truly the whole wound. The third, the one on the right, isn't on the plantar surface. It's a pressure injury of the heel, but you can see the cliffs around it as well. So how do you investigate the cliffs? I've given you two examples here, visual pictorials. So this is a sterile sponge tip measuring device that I can check for undermining and tunneling. So the undermining is the separation at the wound edge, and the tunneling is the deeper tissue. And you can see where the shiny bit is on the left-hand photo. That's the end. So I'm pushing it up to illustrate where the wound base ends or the cliff ends. On the right hand, I'm actually, because it's movable, I'm actually moving that tissue up and down. And this is on the trochanter, so it has a bit of flexibility of that tissue. And I've pushed it up to actually see the base. And what I see at the base is white tissue. So I've taken my sterile metal forceps and tapped that, expecting it to be bone, but it wasn't. It was actually soft tissue, so more like fascia. So I've probed it with the soft. I've also probed it with a hard sterile instrument to check for bone. And any time that you're doing a wound dressing procedure, you need to always be checking for bone, tendon, and infection. You don't know how deep it is until it's clean. You don't know if your wound edges are attached until it's cleansed. So it's therapeutic cleansing, debridement, and refashioning the wound edge. This wound in particular is a great illustration of that. And many times for research, we measure before and after, and sometimes just knowing the wounds themselves. So this patient, before cleansing and debridement, was about 0.2 centimeters deep. And then after cleansing and debridement, it was 0.8. Until we refashion the wound edge, we don't know how big or where to measure from. And this is showing you that some of the slough or the surface substance is actually overlapping onto the peri-wound. Hard to show where the ulceration begins and where the peri-wound begins. This is a superficial wound, I understand, but until it was thoroughly cleansed, I couldn't actually determine the length and the width of what was affected tissue and what wasn't. Now, even hard to get places require refashioning of the wound edges. Now, this is a patient who had a fractured multiple fractures of the lower leg, and he was in an external fixature. So you can see on the left is before and after. And it's really interesting to see quite the distinction that this wound is actually healing. There's healing. You can see some of the pearly edges. But until you remove all that surface substance out, you won't know. And sometimes it does take a little longer. This patient was very unwell. So this was a hematoma on the left lateral leg. You can see the knee slightly there. And they were restless with pain and bumped it. And I think they were also delirious septic at the time. Substantive hematoma. Patient was not a candidate for surgery. And so what we did was initial and serial debridement. And when the patient was able and safe enough, we used some negative pressure wound therapy. So this is about 20 days later, and so there is some tissue starting to grow over that fascia. You can see in the left-hand photo that certainly a cliff, so that tissue is just hanging off. And then as we're starting to approximate that wound, it's starting to attach in the lower surfaces. So it's through a really proactive management. And we were pleasantly surprised with her progress, given the other factors that we were dealing with on a holistic level. So what are our strategies or management options for refashioning? One is surgical. There's conservative sharp wound debridement, and then mechanical, which is probably the most frequent for people who are not specialists in the wound field. And that is gauze scrubbing or using debridement pads. The low-frequency ultrasound debridement is a mechanical debridement, but you do need specialized equipment and training for that. So maybe it's usually currently in the hands of specialists. Now, you've seen this slide before, and it's the paradigm of the step down, step up thinking. It's about healing expeditiously and not eventually. So this is being really proactive and aggressive with the management from day one. So it's triaging these patients and saying, this patient is at risk of losing their limb or their life, or this patient is at risk of this being a 12-month delay in healing. So you proactively provide debridement, you proactively provide the antimicrobial cleansing and the topical application of dressings. You identify and you manage the host factors, and then you try to get the diagnosis or the differential diagnosis for this, and then you tailor the management for that patient's condition, their goals, and their preferences. As you start to get progress, you can then step down to standardized care. You may no longer require the antiseptic wound cleansers. You may no longer require the antimicrobial dressings. But once you've prepared the wound, you can either, as I say, standard care, or you can step up to the more advanced modalities such as skin grafting, skin substitutes, and negative pressure wound therapy. So this is a patient who had surgical intervention, but it was followed by proactive wound management. So this patient had good flow, but he had gait disturbance that caused him to put pressure on that lateral end. He got an ulcer, and then he got osteomyelitis. So he was taken to theaters, you can see from this photo, good blood flow. We followed with serial debridement and proactive management with negative pressure wound therapy. In the bottom photo, or in both the two photos on the right, you can see that everything was healing nicely, looking very healthy, except for one little circle where there was exposed bone. And I said, we need to keep cleaning this out or remove that bone prior to grafting. They went ahead, even though that one area was not growing tissue. And if it's not growing tissue, the wound is declaring something, that it's not right for that tissue to migrate across. The graft took everywhere except for that exposed bone. So they had to go back in, sort of saucer that bone out, and then it healed very quickly after that. So it's determining the flow, determining the goal, preparing the wound for, in this case, negative pressure wound therapy, and then we stepped up to the wound grafting. So is this healing? The answer would be yes. It's quite an extensive wound, a lot of adipose tissue, but if you look at those pearly edges, they are starting to heal. Now this would take a long time with just conservative dressing, so this is an ideal candidate to have the negative pressure wound therapy. And in order for that, we need to do the wound hygiene to keep that wound base and that wound healthy. When we're talking about the wound edges, another thing that when you're looking at the edges is the rolled edge. Now this photo and this pictorial was taken from the National Pressure Injury Advisory Panel from the US, from their stock photos. And this is showing you that the wound edges have rolled over. And this is an example of chronicity and quite commonly found in pressure injuries. But once those edges roll over, it signals to itself that it has epithelialized. So then intervention needs to occur to change that. It is often called epibole or epibole. My colleagues in the US call it, use that term. So you can see two different etiologies, but the same result is that you have those rolled edges. Before you do any intervention for a patient, wound care, you have to have the equipment. And this is just an example of me setting up various items and instruments on my table or my counter in my clinic. You can see that we do use antiseptic cleansers, but we warm them in our baby bottle. Warm them. So just for gauze scrubbing, anybody can do this. It's not very expensive. You moisten the gauze, and in our facility they come 3 10 by 10 gauze squares. I open the gauze and I put in the warm solution and I put it on the wound. If it's on a limb, I may put 2 of the squares on and tie the 3rd one on. So it's very inexpensive. Once I've washed the peri wound, I take that moistened gauze and then I certainly scrub the wound edges to get them clean. I may use other modalities for debridement, but I'm certainly using my antiseptic cleanser to do that wound cleansing. It may be, in some of the articles that I read, it may be slightly more painful and it may be slightly less effective on the bacteria over time, but it is certainly a good alternative and can be used from novice to expert. What we've seen in the last 5 years or so is the cleansing or debridement pads. There's various options here in Australia, and this is a before and after pictorial for you to see demonstration of how effective. And this can be used on the wounds, but could also be used on the peri wound. Our recommendation from this document is that you use an antiseptic cleanser because we're talking about hard to heal wounds. So we want to not only mechanically remove, but we want that chemical activity of bactericidal, whether it be planktonic or biofilm. So you need to do a couple minutes of doing this because you want to remove the seen, but you also want to remove the unseen. Conservative sharp debridement, I've talked about in previous and certainly the whole webinar on debridement. So that's with a sharp instrument such as a scalpel or a curette. In this video, as you've seen before, is I'm just lifting off this surface substance. It's red, it's not yellow, so it's not slough, but it's a surface substance that grows each week on this patient. And we just scrape it off. There's no pain to it. It's not heavily attached. It's easily removed. Whatever that surface substance is, I need to remove that off so that I can put my dressing on to be more effective and actually in contact with the wound base and not the surface substance. But if I'm talking about a epibole or wound edge, I've taken a video to show you just as a demonstration, and this is with the previous pressure injury that I was talking about on the trochanter. So you can see that I'm going in the wound base, but then I start with the cliff, and I'm scraping that cliff to refashion that wound edge so that I can initiate that healing cells. They are proliferating, or once they're epibole, they're not, but to get the proliferation and migration occurring. I'm following that up with antimicrobial dressings and trying to flatten so the surface so that migration occurs. I've talked previously about options for the wound cleansing, that the water and the normal saline do not have bactericidal properties in themselves. With the water and the saline, well, with the saline you have to throw away after 24 hours, and with the water they're single use. What is most popular and certainly recommended from this document is the surfactant containing solutions, or some of the ones I list below, that we want something that you don't, you're using the mechanical, but using the surfactant makes that easier in that it helps separate and lift that tissue without the aggression. So it facilitates and is synergistic with what we're trying to do. So some of the antiseptic I've listed here. So the polymethylene biguanide, it does have antimicrobial properties, and it is a surfactant antiseptic. The octenadine, again, it is a surfactant antiseptic with known activity that is bactericidal. The hypochlorous acid, again, this is quick acting and has antimicrobial properties. And the chlorhexidine has antimicrobial properties, but it does have some evidence in the literature of resistance and some episodes of dermatitis, but certainly has efficacy in regards to being bactericidal. So you have to choose and go by what your local procedures and policy, what you have through your product evaluation. These are 4 options that we can find in Australia. So the Vashi, which is hypochlorous acid, the octenoline, which is a surfactant antiseptic, the microdicin, which is hypochlorous and superoxidized, and then the Prontosan, which is a surfactant antiseptic. This is not product placement or promotion, just telling you the common ones that are available here in Australia. Whenever I'm talking about wound management, it needs a team approach. One person on my team is a picture here of Kate Hirsch. She's a clinical nurse consultant with me in Warrnambool. Amongst our other team players, we do a lot of joint sessions with our podiatry team, counseling support, nutrition. You can't get healing without protein. So they need protein for healing. We have our surgeons, whether it be vascular, plastics, general, all the ancillary community health services, community health nurses going into the home. Red Cross for appointments, getting these people taxis. So it really does take a team approach. And the key ingredient to a team approach is good communication. And sometimes, an example yesterday, I spent probably an hour trying to get the team together because this patient needed an urgent referral back to the vascular team. And he ended up coming in and was transferred. So that effort, that hour investment in that patient paid off because he got the treatment and the teamwork that he required. So when do you refer off? Well, when you have exposed bone, tendon, or metal for the first time, it is certainly an urgent referral to a surgeon. Any wound deterioration where you just don't month after month or week after week continue to say wound deteriorating, wound deteriorating, wound deteriorating. And we have this on our standard wound assessment. And I had a patient who came in on 3 o'clock on a Friday afternoon. And I spent an hour and a half to 2 hours debriding, getting a team approach together, a treatment plan, and doing what needed to be doing for this patient. But when the written information came from the facility where he was at, for 3 weeks, it started off deterioration plus plus, and then deterioration plus plus plus, and then he ended up in my clinic on a Friday afternoon. So anytime that you see wound deterioration, that is a call to action, that something needs to change. And that may be that you're referring that patient off to a more specialized service or more advanced or skilled hands. So if it's beyond your scope of practice, it's not a failure to say so. What I remember in my nurses training, one of my instructors said, Terry, a good nurse knows their strengths and their weaknesses or their limitation. And as a nurse practitioner, I certainly have to be aware of my limitations. So this is a patient who came into the clinic. And yes, I could have cleansed it and repacked it, but what that patient actually needs is that tissue to be cut away and see how much unhealthy tissue is in that cavity, and that cavity needs to be cleaned out either through surgical debridement or low-frequency ultrasound debridement. So saving that false bridge is doing that patient no further benefit. So I'm going to conclude on, this is a prime example of a wound edge refashioned, where you can see that you've got it clean, some light bleeding, so it's clean, it's moist, so the balance is good, and it's free of debris so that those cells can proliferate and they can migrate across. Don't forget, we have 2 more webinars. So on 23rd of July, I will be talking on proactive redressing of the wound. So this is talking about mostly antimicrobials, but some non-antimicrobials that are proactive. And then I conclude on the 6th of August talking about implementation. I'll now open up for questions and answers, and I thank you for your time and your interest.
All right, I just wanted the video to end there and to give final credit to Fitz Media. It's actually a media company here in Warrnambool, so I don't have to travel, which is really good in these COVID times. So we've had over 300 attendees, 335 at the most. I'm now going to answer some of the questions. I'll try to get to all of them. We've got a bit of time. It's only 6:30. So tying the knot. I wish I had show and tell here. So in our facility, we get 3 packs of 10 by 10. So I just open them up because low contact, put the fluid in there. Then and I've got gloved hands. I'll put them, the 2 on the wound, and with the 3rd, I'll open it up so it becomes quite long, and then I'll tie that around the limb. I think my podiatry colleagues down the hallway use a tubular bandage to put it on. Some people use a plastic bag or from the actual package. Other people just put a film dressing over it. We know that once the fluid gets on there, gravity takes it. But what I'm trying to do is we know that for things to be effective, they have to actually be in contact with the surface that you're wanting. So that's one way for it to stay on there. And sometimes I'll place a towel depending on how large the surface area is. Just trying to be practical about it. So you may be able to provide me with some different options for that. People who've come to the clinic have said that they've taken that back. In regards to their certificates, I'll bring these questions over so I don't have to look sideways. The certificate, Eva from Convatec will be sending the link to the previous recorded webinars as well as the certificates. She just asks for you to be a little bit patient. A question about, am I aware of the literature comparing different wound cleansing agents such as Prontosan versus microdicin, or from personal experience? In my facility, my service, our service in the wound management uses something different than the podiatry service because we're using it for 2 different goals or initiatives, I should say. But I've talked about in the previous webinars, and Dr. Lee, I couldn't quickly find the reference for it. It's Johanny and Matt Malone's group in Newcastle, and if you Google Scholar, you'll be able to find it, or I'll be able to make sure that in the last recording I put up that specific reference. But I know that I've already recorded the antimicrobial webinar, and I have discussed that article in there. Right, if I haven't answered that well enough for you, I've answered it. Another question was, could you remind me of the rationale of warming the cleanser before wound cleansings? So Dr. Bill McGinnis, for those of you in Australia and New Zealand, are probably familiar with Bill, who now resides in Tasmania. Lucky you guys, we miss him in Victoria. His work several years ago, and again, I don't have quick access to the article, so I'm sorry, I'm trying to answer these on the fly. This is live. That when the wound cools down, either due to time that you've left it exposed or the solutions that you put on it, that it decreases the cellular activity or the meiotic activity of the wound. So the least frequent dressings that we do, the better. And that's why we've moved away from 4-hour normal saline packs. For one reason, there's lots of them, but that was one, and warming the solutions. And when I talked about in the wound cleansing webinar, that there were different ways to warm that solution. One is our solution in the clinic in Warrnambool here, and that's putting in a baby bottle warmer. You can also carry the individual sachets in your pockets so that it's body temperature when you go to put it on. If they're sealed bottles or ampules, you can also put them in a bowl of warm water. Before we did the baby bottle warmer, that's what we used to do, was put it in a bowl of warm water to bring it to a body temperature or above. The one thing you don't want to do, that I would discourage you from doing, and that's using the microwave, because the solution can be inconsistently warm and we have a higher chance of maybe having it too warm or causing harm. So we want it to be at least body temperature. So I'm moving up to the other question. A wound where the wound bed is covered with adipose tissue heal well after using VAC dressing. So thank you for your question. We have. So as long as it's, again, it goes back to viable tissue. That if, and you can, adipose tissue is quite bubbly yellow, gelatinous when it's healthy. It starts to become very desiccated and hardened when it's non-viable, depending on the stage of that autolysis. But we have been able to grow. The thing that you want to do when you're using negative pressure wound therapy is to make sure that you get that wound clean, and that is the preparation that I've talked about. So that's therapeutic cleansing, the debridement, and refashioning those wound edges, even with negative pressure wound therapy. Okay, let me go back. There were some other questions about, so one question, thank you, Sally, for your question about the gauze. There are lots of versions to choose from. I find that the 3-pack of the 10x10 sterile easy to use because it meets my needs in my service about opening up and putting the 2 on and tying the other one on, or just if it's a flatter surface, putting it in, or in a cavity. I know that it's sterile and it's just easy access. I know some people get the greater packets, or they come in the dressing procedure tray depending on yours. So in the basic, I think it's about 3, and in the complex, there's 5 squares, and then there's some gauze balls, but you can undo those gauze balls and turn them into squares if you need more. So out in the district, or going into people's homes for wound cleansing, I would still encourage you to use the sterile gauze, but having discussions with my colleagues in the US, sometimes they don't use the sterile. So again, you have to go back to that risk-benefit matrix and knowing your patient. The type of gauze does matter. So there's a woven and a non-woven. The woven gauze, what you don't want to do is, and that's why we've moved away from cotton balls, is not leaving fibers in the wound to set up an inflammatory response. Going to, let me see if I've got more questions. See if I'm going the right way. There was one question about scraping underneath the wound edge with the Epibol or Epiboli. Yes, I was scraping the wound edge, and sometimes if that is unsuccessful, and you can flatten those edges, or to keep, when you have those rolled edges, sometimes pressure will do it, sometimes negative pressure will do it. Sometimes making sure you fill in those spaces will help it come back up, so that, but it needs that aggression, that debridement, to actually restart that healing process, because it actually has turned itself off when it's completely rolled. So you need to sometimes, and I use the curette to kind of open that back up, and then using the dressing regime to fill and flatten, so the migration occurs across. And many times, as I said, that rolled edge occurs because you don't have the wound edges attached, and they're starting to migrate down, and that area isn't filled. And that's why we go back to the principle of wound healing, of healing from the bottom up. I hope that answers your question. One question from about when I talked about warming the solution, about reheating and reusing. So we put our bottles in the heater or the warmer, and turn it off at the end of the list. We've been doing that for quite a few years, and to my knowledge, it hasn't spoiled or damaged the efficacy of the dressing. But I do turn it off at night. Let me get some more questions out there. Okay. How do we determine the interval of change of dressing? Frequent opening of dressings might result in exposure to infections. What should we do? Thank you, Liza. Good question. So the interval of the dressing change depends on your individual patient. So there's lots of reasons why we change a dressing. One, the manufacturer will tell you that this dressing provides its active ingredient for such and such time. So that's a predominant factor. The other predominant factor is that the level of exudate, and many times it's that level of exudate that will predict. So I can say to a patient comes to me, I've assessed them, and I say this dressing should be changed at least twice a week. Now, if I know that patient, and I looked at the old dressing and know that this dressing was put on Monday, today's Thursday, and it's only 3/4 full. So I'm fairly safe in saying that twice a week is probably going to be safe for this patient. But if the patient rings up the service on Sunday to say, my dressing's saturated, then that dictates that that dressing has to be changed on that Sunday if physically possible. Sometimes distance or the service is not open does impede that, but in an ideal world, then that would be changed if it leaks. The type of dressing that you've put on, so if it's an absorbing dressing, or if it has active ingredients such as silver, we're trying not to change it every day to allow that active ingredient to penetrate into the wound surface. Yes, the more often we change it, especially in the hospital situation, the greater risk that we have of cross-contamination or introducing bacteria into that wound. So if we can use our technologies and our modern dressings to decrease the frequency, and while we're doing the dressing procedure, to clean, to debride, to refashion, then it increases the efficacy of our dressing. So I hope I answered that question. And then as I keep repeating, is that every time you do a dressing procedure is always looking for those subtle signs or secondary signs of infection. If that wound is not progressing, then you have to keep asking yourself why, and keep looking for the answer. Okay, let me see. Let me go the other way for more questions. Would you recommend inducing light bleeding to the wound base during debridement to promote healing? Well, in this document, and I hope that you all at some point get a chance to read the document. I know that Eva from Convatec sent out the link to the document, but in discussions when we were developing the document and talking personally with Randy Walcott, when he's talking about refashioning the wound edge, and you can see when I concluded on the last photos, there was some light bleeding at the wound edges. Bleeding is not going to hurt that wound. So many of these patients, certainly my cohort of patients, most of them are on some level of anticoagulant. The key is that you have confidence and competence in what you're doing, and that you control that bleeding. But some light bleeding, some serous exudate, hemoserous exudate coming out of that once you've completed the cleansing, the debridement, and the refashioning, that's fine. And that's why many times after all of this, for the first post procedure, remember that I have access to very aggressive types of debridement. I'll often use an alginate because it has that hemostasis property. So it's knowing your patient, knowing your wound, but light bleeding does not frighten me. And many times when I'm using a low frequency ultrasound debridement, there may be lots of bleeding, but once I stop, the bleeding stops. I've never had to send my patients to the emergency department. Thank you for your kind words that you're enjoying the webinar and that you're finding the information useful. The whole idea, folks, of having an expertise is sharing that knowledge. So I've been very grateful to Convatec and for the invitation to participate in development of the document itself, but also having the opportunity to talk to you 6 times about the document and my experience, and trying to give you that practical information. So this is a question from Lori. Thank you for the question. It's just wondering, what do I recommend as a moisturizer instead of sorbolene? Again, try not to be product placement, so I'll try to talk in general. What we have learned, and what our dermatologist, I think it was in 2018, I went to 2 different conferences, and 2 different dermatologists absolutely said to cease using sorbolene, because it was actually doing the opposite of what we wanted to do, and that was increasing the inflammatory response of the skin to it. It also causes a buildup. This was their words, this is not my work. But what we're looking for, if you're using a pH neutral skin cleanser, and so there's and I'll probably forget companies, but the Eagle, the Hamiltons, the QV, Dermavine, all those are pH neutral, so moving away from soap, and they usually have moisturizers that go with them. So my advice to my patients is to go talk to your local chemist and ask them what you have in regards to your leg. So if they have really hyperkeratotic limbs, that they might need an ointment more than a lotion. So they get the cleanser, but they also get the moisturizer in the same brand, so they work together. And then from there, they can go to a grocery store if they have them in the grocery store and get them, or get them online for a little bit cheaper. So I'm not brand specific, but I know that for a cleanser, if I'm not using an antiseptic cleanser for the limb, I want it to be a non-soap, pH neutral, and then I follow through with hopefully with the same brand. So Lori, I hope I answered that question. Do you moisturize skin prior to using this skin protection? Good question, interesting question. So if I have macerated peri wound, no, I'm not going to put a moisturizer there. So where I'm putting my skin protectant, I will not put a moisturizer, but certainly the skin above that is usually very dry. So, and remember, if you're putting an adhesive dressing on, you can't moisturize that area there either. And usually, especially with the silicone dressings, it kind of uh, maintains that moisture, so that you can usually see where the dressing was, that it's not desiccated in that area either. So no moisturizer before you're putting adhesive, but once you're putting the adhesive dressing on, go for it. And when we used to talk about like steroids, topical steroids, they used to say, to minimal use, but now they're saying liberal use, because people were under utilizing that. So this next question from Anne is about a personal experience. And yeah, and I talked about how important it is, especially for those new moms, in getting that wound healed quicker, um, the importance of debridement, and many for the time these patients are um, having a lot of things going on in their life, so the sooner the better. So thank you for that, Anne. The question about the use of local anesthesia, how and is it really successful? So in the webinar on wound cleansing, I talked about Anne Purcell's body of work on local anesthetics, the lignocaine and the combination lignocaine prilocaine, and I gave that reference to that article. And from a personal perspective, Elba, I find it successful. And as I just spoke about in the webinar, if it's not working for this particular patient for whatever reason, then I've developed that rapport with them that I'll stop. And I tell them, because I'm down here working, that I'm not able to read fully their body language, that they have to find their voice. They have to tell me. And it's them being part of that decision making. And I've had some colleagues who actually let them do the debridement for pain, and a lot of that is anticipatory pain or anxiety. And so taking the time, and I know so many of you are time poor. I have the luxury in my clinic of scheduling my patients for the time I need. I get that. But I do a series of getting them to take the oral analgesia coming in, using the warm products, and using either EMLA before they come in. And I have a pictorial of how they can do that. So that's prescribed. If they don't need that, just in the topical lignocaine. And yes, I do find it very successful. So next question by Anne, in an aged care facility, identifying a wound management club, how do you need? So yes, there's a national organization. So Wounds Australia, so Google Wounds Australia. And they have a previous campaigns on finding an expert or finding a clinic. And they do have clinics, or you can use the contact numbers in the webpage for Wounds Australia, and they can put you into a local center in your state or territory. So thank you for being able to promote that. So Marilyn asks, are rolled edges not healthy? Right. So no, they're not healthy. So they need to have the what I've talked about in regarding to refashioning those wound edges through the strategies that I talked about in the webinar. Sometimes when my measures or strategies in the clinic aren't working, then I have to send them off to a surgeon to refashion or saucer or rim those wound edges to get them started again. That's the last resort, but sometimes I've had to do that. Any comments on choice of scalpel versus curette or instruments to refashion the different types of wound edges? I'm very comfortable, very skilled with the curette. I'm in awe of my colleagues from podiatry. They come in, we share care a lot of patients. They come into the clinic and I'm just totally amazed at what they do. I'm not as bold as they are with the scalpel. I do use a scalpel every day, but just not as proficient as they are. So a scalpel, if you're comfortable, remembering whatever you're doing, you need to be competent and confident in the measure you're doing. Above all, we want to do no harm. So that's the best I can do. And if you want to get that skill, ask your colleagues who are currently doing it if they have a education program, or seek out an education program that can provide you with that skill. The more people that we know who can debride and treating those wound edges, the better path to healing for our patients. This talked about a patient after hematoma, which was self-drained, was left with loss of sensation. No, loss of sensation is not normal. So it's an indication of some level of trauma. Whether it's temporary or permanent is yet to be determined. but it is not a normal result. And even with some procedures such as, when the vein stripping, it's an inadvertent side effect when they grossly pull out those veins, and it happens with trauma. And so with any trauma, it should be assessed. Danny is for non-healing cancer wounds on the face or near the eye. So in the first webinar, I talked about the rationale for non-healing, for hard to heal wounds. And so with the understanding that the hard to heal wounds are healable wounds that just haven't gone on to heal. So for your non-healable wounds, there's some caveats. And I've talked that through the series of the webinars, is that whatever you're doing for your patients, the benefit has to always outweigh the risk. And so for some of these patients, you're not going to be doing aggressive debridement, and you may be only limited to gentle cleansing. The main thing is you want to treat the symptoms, and that is many times the odor. So for your non-healable or palliative wounds, you do have to be careful. And sometimes dry healing for these patients will manage their symptoms better than the strategies talked about in the wound hygiene, because for the hard to heal, we're talking about healable wounds. So is it okay to use hands rather than forceps when cleaning a wounds with gauze? Yes, gloved hands, to get that feel, that abrasion. Sometimes you can contour better, but remember that it is trying to attempt to no contact with the actual wound bed. So you're using those layers of gauze to do that. And that's not an unusual strategy, something that I employ in my clinic, to be very honest with you. I have talked about, am I going to at some point talk about the role of different agents post-wound cleansing, such as the role of Kennicomb? No, I'm not, because I'm not a pharmacist, and Kennicomb is something that I don't use in a general sense. I think most of your acute wounds, more frequently in your plastic wounds done by plastic surgeons, will use that post, but it's something in chronic wound healing we don't use a lot. Now I'm running out of time, so I may have to conclude. And yes, the microwave can potentially alter the chemical structure, and another reason not to put it in the microwave. Recommendation to treat hypergranulation tissue. So I did talk about that on the last webinar, talking about healthy and non-healthy wounds. And I talked about debridement is important, and some of the antimicrobials to help decrease that bile burden. So when you get access to the full webinar, or go to the document itself as well. I'll finish on this one last question. Eva will download all of these questions, and we'll try to get some of these answers for the next webinar, or we'll probably have a Q&A on the website eventually. So for the hyperkeratosis or the keratotic, so they need to be determined whether these keratosis are actually benign or malignant. So if they're bleeding, then you need to have the full diagnosis. If they're benign and they're multiple, again, you have to determine what is the goal and what is the most beneficial for this individual patient. If you have a heavy bleeding wound, then obviously the alginates are good for hemostasis as well as absorption. So I'm sorry that there are more and more questions that I can't get to because our time is running out. So